Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this story episode, we are going knee stories.
We are. And for this one, we have a variety of different knee stories. We have some patella stories, some fracture stories. We have your classic ligaments, which we actually didn't get too many of. I actually feel like, and then we have some other stuff like bursa and loose bodies and stuff.
Oh, just loose bodies.
Just
whatever.
Typical. I feel like we actually got so many stories that involve the patella.
Oh, interesting.
So I split it up a little bit, but I did put one of the patella ones first.
Okay. Well, I was just really stoked that the anatomy portion snuck its way into our story episodes. I'm just saying.
Do you want to start it off with some anatomy?
Yes, please.
So you have this thing called patella.
Oh, got it.
So before we get started with our listener stories, Randy, do you want to kick us off with a story? Do you have any knee stories that you can think of?
Ooh, gotta think about it. I know one knee story that was interesting for me is we had a cross-country runner that had like patellofemoral pain, right? We adjusted his load, we did some rehab, and like it got to the point where he really wasn't getting better. And when we sent him to the doctor, there was really nothing that really lit him up. So it was just like, oh, just kind of progress him when he's ready and stuff like that. And then just one day he just ran and he said, oh, it felt great. Oh, okay. It miraculously got better when he started running. So sometimes you just never know. Like, yeah, we did everything you were supposed to do. And sometimes just getting back into the sport helped him out.
Or he just needed some time off and then his body kind of figured it out.
I guess, but it still was hurting when he was not doing anything.
Oh, that is interesting.
Yeah, but once he started running again after, I think we had him out for like a week on top with him doing like rehab and stuff, and didn't see much huge progress. That's why we sent him to the doctor, and then he just ran one day and was like, oh, it felt great. It was pretty odd.
A week's not too bad.
No, could be worse.
That D1?
Yes.
A week at D1 is like a month.
Yes. Yes, there was a lot of pressure for this one.
Okay, you want to go to our first story?
Yes, let's do it.
So this is from Sica G. She said, I had a patella basically break in half horizontally.
Oh my gosh.
Non-contact. Super crazy. With a college football team, basically they just planted hard to stop, and we think the eccentric force through his quads did it. He obviously had some pain, but it wasn't too crazy. Mostly he just knew something was wrong. On the field at first, we thought it was a patella or total knee dislocation because of the obvious deformity. But on further eval/palpation, we saw what was actually going on. Neuro and vascular were all within normal limits, so we splinted and loaded him into my car and took him straight to our ortho's office for imaging. They did surgery, I observed, that's cool.
Really cool, yeah.
And our ortho drilled holes in both halves to basically suture it back together. It was locked in an extension brace for 6 weeks. He had a ton of scar tissue that we had to break through in order to get his flexion back. Ended up doing...
I was going to say, I bet that felt amazing for him.
Oh, yeah. Made sure he came back.
Oh, yeah.
Every treatment session. He had a ton of scar tissue we had to break through in order to get his flexion back. Ended up doing an MUA to help, which I had to look this up.
Yes.
A manipulation under anesthesia.
Ooh, that's terrible. That's the thing that you tell your patients to scare them to. Hey, you need to be on your rehab.
Seriously.
Man, I've never seen anyone actually have to go through it, so that's pretty tough.
And the ortho let me do part. Oh my gosh,
that's what
really
a cool experience.
He came back to football in about 12 weeks.
Oh, that's not bad.
No, it's not bad. We had a bunch of blood work done as well because we were worried about the possibility of deficiencies causing it, but everything came back normal. Doctor said it was just a freak thing. Athlete did have a history of bilateral acetabular labral repairs, but had returned from each of those with no complications.
Man, I'm still like non-contact. Like his own muscular force produced that fracture.
Isn't that what your Golgi tendon organs are supposed to stop?
Technically, yes. but mostly to protect the tendon. The bone's usually pretty strong.
Yeah.
That's pretty brutal.
That's, non-contact. Just straight in half. And the best part is we have a picture.
Oh,
yes. We have an x-ray.
Love it.
Yeah, so we'll put that in our Facebook group. If you guys are not a part of it, it's facebook.com/group/ATcornerPodcast. We actually have 8 pictures from this episode that we're going to put
Oh
up.
my gosh, that's a lot.
Yeah. I had a softball girl who got drilled in the knee with a softball. And she was pretty tender.
Uh-huh.
I wasn't really sure if it was a patellar fracture, but like she was pretty tender. So I sent her for x-rays just in case. I mean, I'm pretty sure it wasn't, but
yeah,
just in case.
Well, shoot, I had just this past weekend, I had an athlete that was kicked in the knee during soccer who was fine when I saw it happen, and then to get the call, it became the worst pain ever.
Of course, it's soccer.
Yeah, that's my knee story for the day right there.
We actually have the next 3 are all patellar tendon avulsion fractures.
I'm pretty sure I've actually seen patellar tendon rupture.
Patellar tendon rupture or avulsion fracture?
No, the rupture.
From what?
This was when I was a student. This is when I was volunteering. We were at, it was at a track meet. We were visiting another school, and they were a little short-handed, so we decided to help them out a little bit. And I guess like in the stands, this like older gentleman like fell, right? So they had us go over too to like see how this guy was. And I was looking at his knee. It didn't look right. Like I feel like it looked flat. So like you're expecting a bump where the patella would be. It wasn't there.
That would be an onsite.
So I'm pretty sure he ruptured it. I mean, at this point, I was like, I wasn't in a program yet, so like I can't even remember what we necessarily did. But I do specifically remember, like, I'm pretty sure this gentleman ruptured his patella tendon, not his patella, not the bone.
Just like going downstairs or something.
I think he fell on it or something.
Oh.
I think that's what ended up happening. But like, I don't know if it ruptured and then he fell, kind of thing.
Oh.
Yeah. But yeah, I remember that.
That's crazy. I feel like I have seen a ruptured quad, but
Oh, really?
Like where it like bulges up.
Yeah.
But I don't think it involved like
crazy.
patella tendon or quad tendon.
Huh.
It wasn't my athlete, so I don't know much about it.
Yeah, I don't have much of the follow-up.
No. One of the weirdest times that I've seen that I've been looking at a knee was when we had our football player. I've told the story on the podcast before, like a million times, I think. My first 911
Oh, yeah, that's right.
Was when we had a football player who he was running to the sideline, so this really shouldn't have happened.
Yeah.
And one guy just like took out his legs from behind, and he ended up, his fibular head had moved anteriorly.
It's not supposed to do that.
And when my preceptor and I were both, when we got there, because it was like right in front of us.
Yeah.
My preceptor was kind of checking out his patella. Like it kind of looked, because there's a deformity. Yeah. It kind of looked like there was like a patella, like dislocation. But it ended up that was actually the fibular head that had moved proximal or moved anterior. So that was a splint and send.
Yeah.
Actually, the EMS took forever because
that was
the first rig they sent like couldn't do anything. So then, and they didn't even hook him up on pain.
Their job was to stabilize him.
Yeah, no,
Even
they didn't
you
do
guys
anything.
did that already.
Yeah, and this kid lost like D1 scholarships.
Yeah,
it was bad.
I mean, shoot, like when you think about it, you gotta be careful of those that like a dislocation like that, because you have the nerve that runs just posterior to the fibular head.
Yeah.
So that could definitely get caught up.
I've had actually one of my football players recently, not this season, but before, he had fibular pain and nerve pain that would run down his leg. And the only thing that we could get it to to go away was if I did mobilizations of the fibular head.
Ooh, interesting.
And so I end up taping it with leukotape to kind of like act as that mob when I wasn't there.
Basically did a impromptu mulligan tape.
Yeah.
I think you should talk to Mulligan about that. Let him know. Be like, hey, I got a new one for you.
You should add this to your technique. Okay, you want to go to the next one?
Yep, let's do it.
You can read it.
So this one's by Emily G. Last year, I was called to go to one of our auxiliary gyms for a basketball athlete who landed weird from a jump. This kid was calm as could be, but his kneecap looked like it was sitting up in his quad. Oh yeah, that's a bad start right there. And it looked so weird. He said it wasn't that painful, so he let me feel around, and I could feel the entire tibial plateau.
Oh my gosh.
I want to say it's pretty cool, but man, poor kid. I thought he had ruptured his patellar tendon, but it actually was an avulsion fracture. Still couldn't believe how calm he was the whole time, especially with all his teammates watching and screaming at how weird it looked.
Oh my gosh.
I put a straight leg brace on him, and parents were nearby and took him to the hospital. We did call the ambulance, but they literally didn't know what to do with the kid. Interesting. Vitals were fine. Pain was pretty low. Overall, they were like, well, if he can get to the car, he doesn't need to go with us. It was a weird one for sure. That's pretty cool.
I know.
I wonder if it being an avulsion fracture, if that makes it better, right? Because then you can just pin that piece of bone back, right?
Well, that's what I'm thinking, because the tendon is intact.
Yeah. So you don't necessarily need to like repair that.
Okay, so this next one is also an avulsion fracture.
Okay.
And the reason why I include all three is because some of them like presented a little bit differently, which is also kind of the point of this episode, is like you can have the same injury, but it could have very different outcomes. This one is really interesting and something that I think that people could take into consideration when they start practicing with their students or like practicing for the upcoming season.
Oh, definitely.
So this is from Emily M. She said, I had an avulsion fracture of the tibial tuberosity that was wild to see. I had a skateboarder who stuck his foot out to stop himself going down a hill and felt a pop.
Ooh.
He had large knee pads on, so he couldn't see the patella at first, which made it very difficult to get a diagnosis because he couldn't tell us anything due to the pain. Oh, I hate that.
I know.
When they're like, when you're like, okay, what's happening? What are you feeling? And they're literally like, not able to tell you. You don't even know where it's hurting. Yeah,
that one's tough. That sucks.
Once the pad got taken off, we saw a huge deformity where his patella was, even with his femoral condyles.
Oh, man.
We end up splinting with cardboard splints, that's all we had, on the bottom and putting foam over the knee so it didn't get hit or anything. We transported him off-site because it was a camp, and I never heard about how it went, unfortunately. It was the hardest thing I've ever had to help splint, I think, because he was stuck in a lot of flexion, which made it very tough.
Oh, yeah.
So that's what's really interesting because, you always practice with like a straight leg knee. But
that's true.
What happens if your patient is in knee flexion?
So that's when we were going through our like splinting comps and stuff like that, we had to splint them in very, very weird positions. We did practice that, and it is not easy.
No, it's not.
To splint in the non-ideal positions.
Right. What are your tips for that?
You just gotta do your best. Like if you have the vacuum splints, not a lot of people think about it, but like you can morph the beads in the vacuum splint to where you need them. Mm-hmm. So like
to fill space.
Exactly, or to like add certain rigidity into another spot that normally wouldn't be there unless you massage the beads to that way. Mm-hmm. I think that was the biggest thing that we learned is like, hey, you got to kind of play with your equipment a little bit. I think the biggest thing is like just do your best. That's all you can do in those non-ideal splinting conditions.
I want to say the weirdest thing I've splinted was an elbow dislocation, but it wasn't that bad because his elbow was in flexion. It was just the fact that his ulna was moved posteriorly. So
oh yeah.
But I had a SAM splint, I think, so it was kind of easy to just like mold around.
Nice. Good old Sam splints.
I know. And the kid wasn't freaking out, so that helped.
That does help. I'm assuming that was jujitsu.
It was.
Yeah, I figured.
It was. So this
you got me, especially when you said, "Oh, the kid wasn't freaking out." Like, oh, that sounds like jujitsu.
He was also. It was a competition where they wear gi, which is the robes.
Uh huh.
And so initially, when I'd gone out on the mat, I didn't see it.
Uh huh.
I just felt it.
Oh,
and then I was like, yeah.
This is a problem.
So this avulsion fracture, actually, from Emily, we do have a picture.
Nice.
Yes. So we'll put that up too.
Man, this week's gonna be full of pictures.
And this next one has a picture too.
Yes.
So you get to see like the differences. I think, just these two have of the avulsion fracture. So you can see the two. You want to read this one?
Yes, this one's by Anonymous. Avulsion fracture of patellar tendon from tibial tuberosity and fracture site size of a finger. Ooh, that's a big footprint there.
Seriously.
It was a visiting athlete, actually, lower level football. I don't really know how, other than his knee buckled, and it was an avulsion big enough that my finger fit in the deformity. Dude, that's pretty brutal. We had to cut his pants to find the patella, which was halfway up his thigh, and he had no feeling at all.
Ooh, that's bad.
He was actually on the ground laughing and making jokes with his coaches as I was palpating directly over the fracture site. He was a freshman, so I suspected maybe Osgood because he was in a growth spurt, or he was just really tight from lack of stretching. And then, like Sandra was saying, we have the picture of the x-ray. So I'm intrigued to see that.
Mm-hmm.
Dude, that's brutal.
So, I mean, it makes sense. A lot of these are from planting.
Yeah.
But we also...
Which, again, like you said, does make sense.
A lot of these knee injuries come from football and rugby.
Yeah, that's true.
And then we have some, like, odd ones. We have, like, a performing arts one later and
okay.
lacrosse and...
That's what I was kind of thinking, too, about this kid maybe previously having Osgood Slaughters. It seems like it makes sense.
Well, it kind of makes a nice base that can come off.
Yeah. Boom. Like that.
I wondered, when they have Osgood Slaughters, and they reattach an avulsion fracture, do they shave down the
Oh,
Osgood
that's a
Slaughters?
good question. I don't know.
Or they're like, here you go, you get to keep the bump.
I don't know. That's a good question. I feel like...
Because they do that anyway. Like, if we're really bad Osgood Slaughters, they go down and shave it, right?
I think so. I think if it's really bad and it's not responding to treatment.
Right.
Yeah, I think so. That's interesting. Yeah, I don't know. That's a good question.
Doctors? Anyone?
Yes, any surgeons out there, we'd love to hear the answer to that one.
Anyone who helps with surgery?
Yeah, that's true.
So this next one is a tibial plateau fracture, which I've actually had one of these with an ACL.
Yeah, I haven't had it with the ACL, but we had it when we thought someone might have tore their ACL, and it ended up being a tibial plateau fracture.
So one of my basketball athletes, when I was working at the high school, she was at an away game, and she comes back to me in the clinic the next, I think it was probably it was a Monday, so it must have been over the weekend. So
yeah, I think so.
It was probably, and they don't play on Saturdays, so it was probably like 3-day-old ACL.
Yeah.
And I was like maybe 6 months certified. And she comes in and she's walking and, she's telling me about her knee. And she said, and she's like one of our best players.
Of course.
And she's like, yeah, I couldn't keep playing. And there was no athletic trainer, I feel like.
Oh, that's unfortunate.
Yeah. Because I was like, did you get seen? And she's like, no. So then which is weird because I feel like usually they sent me if there was no athletic trainer.
Yeah.
But somehow she wasn't seen. And so then I was like, okay, well, what did you do? And she said she'd hyperextended. And I was palpating and she was just having a lot of pain, like kind of medial joint line.
Okay.
And then I did all my knee tests, and I was kind of like torn between ACL and meniscus. And so I was talking to her coach, and I was like, like, I need to go. I mean, she's going to her doctor. She's going to go get seen to get imaging because obviously, but from what I can tell, I was like, I'm really torn in between these two. And at that point, I was like, for some reason, my head was like blocked and like, can't be both, right?
Yeah.
Like, you're 6 months certified. Like, and I was like, I'm really torn between these two. And then the next day, she doesn't show up. And I talked to her coach, and she was like, yeah, so she said that she's casted. And I was like, oh my goodness, like, what did I miss that she's casted? And I went home kind of like, oh man, like, I really like, how did I miss something that like she would have been casted? I was like, I really don't like what? She comes to me in a straight leg brace, and she's like, look at my cast.
Oh my gosh.
And
that's
I was like,
not the same thing.
I was like, you know how much you made me doubt myself? It ended up being ACL and meniscus and a tibial plateau fracture. Yeah.
I like how we call the brace a cast. That's funny.
I know. It really scared me.
Oh, yeah.
Which I feel like, actually, I've never had an acute ACL. I've never felt an acute ACL because I've never had anyone. That was probably the closest to.
Yeah.
And I had a soccer player who did a partial ACL.
Oh, okay.
But other than that, I really haven't, knock on wood.
Yeah, seriously. I've had a couple, but man, dude, they've all guarded really bad, really early on.
Really?
Yeah. So it was hard to get a good like lockman or anything because they just guard so quickly.
Yeah, I had one of my coworkers had an acute ACL, and I was like, "Can I please feel it? Can I please?" And so I just went over and I was like, just trying to feel it, and it was already guarded.
Oof.
Yeah. Yeah.
One of our professors through the program. She was ACL deficient.
Oh, yeah?
Yeah, and so we got to practice what a positive would feel like.
I feel like
we couldn't do it very often because she's like, okay, it starts to like kind of bother me after a while. But we could at least get one lockman in each one of us, so that worked.
I know. Remember when I was practicing lockman on you, and you'd be like, "Oh, my knee's sore. I need to stop."
Yeah, you do get sore for that. I had one time I was showing students, and one of the assistant ATs came over to help them because I was the patient. And after he did a couple, I was like, man, my ACL is kind of sore.
Don't go play soccer right now.
Yeah, seriously.
We actually have a tip and trick that someone sent in. I believe Marissa S. So she said, lever sign or Lely's test for ACL was a game changer for me. Small hands and a wrist injury aren't helpful. I use my metal water bottle instead of my fist and feel much more confident in testing ACLs.
We had a surgeon that was very passionate against the Lely's test.
Against it?
Yes.
Why?
I wasn't there. I just heard it from other students who were there for the doc visit. And I guess it came up for that visit. I don't know. But he was very passionately against it.
He obviously knows him personally.
Probably. He's probably like, yeah, that Lely guy is annoying.
I have never used the Lely's test.
I've never used it. I think I've used it as like, I don't want to say a joke, but I think I used it as like, oh, let's see what we get. I've never used it on someone that I suspected of an ACL. Maybe I should give it a try.
Yeah.
What is the literature on it right now? Because I remember as a student, like it was pretty new. So I wonder how good it really is.
I thought you were asking me for a second, and I was like, you need to ask that question to yourself.
No, I just never really thought about looking into it. I think I should now.
I mean, we're on the topic of knee injuries.
I mean, it's been a few years, so I feel like something's got to be out.
I know, and I feel like more people are using it.
It became popular.
Mm-hmm. You know what really helped me with my lockman is I went to help out with physicals at a couple different schools, and I was put on the ortho screen, and I did a lockman on like hundreds of people.
Yeah, that helps.
And then I was like, okay, I can now do this.
You know the one that I cannot do for the life of me is the reverse lockman. Or the prone lockman.
I don't know what that is.
So it's a variation of the lockman where for like your bigger athletes that you can't get your hand around, you can actually have them lay prone on the table, their leg off the table a little bit, so their knees off, and then you can actually do a lockman that way where you're pushing towards the ground.
I feel like I'd get tripped up by the calf.
Yeah, I was shown how to do it, and like I was like, I can't get this. I cannot get this angle of push, pull deal. I don't know. But it is something to keep in mind.
Yeah. This next one is tibial plateau fracture.
All right, this one's by Danielle B. Kid planted and hyperextended knee. Was able to walk off the field with no help, some discomfort, no pain except over the tibial tuberosity. Full range of motion, some weakness. Diagnosis, no ligament damage, tibial plateau fracture with bone bruising on femoral condyles.
Ouch.
Yeah. He was a football player. It was my first year as a full-time AT, so I was still apprehensive about my own skills. The visiting team had a physician who I asked to come check out his injury. The MD said it was an ACL tear. I wanted to trust him, but my gut was saying not to. I wrapped some ice on him and had him sit for the last 4 or so minutes of the half. When I took the ice off, he had a good bit of swelling, which concerned me. His family was in the stand, so at halftime I pulled them into the locker room and told them what the physician said, but also that I thought it would be a good idea to take him for an x-ray based off of where his discomfort was. I still have no idea how he was walking or even okay with me palpating without reporting any pain. He sat out the rest of the season and did PT and returned the next year to play and had no issues. I was really glad that I didn't just send him home that night and wait to get him an ortho appointment set up. I still love to refer to the physicians I work with for second opinions and help when I'm unsure. It definitely helped realize that no one is perfect, even physicians, because none of us have x-ray vision. But it especially helped with my confidence in trusting that I knew what I was doing with special tests. Looking back, I wish I would have pulled out my tuning fork, but because of that experience, it's one of the first tests I do when I suspect anything bony. It's true, physicians are people too. They're just going off of what they see as well.
Anytime that I have, like last season when I had a series of odd injuries that I just kept getting wrong, I just think of that one time that I had an athlete who tore her meniscus, and both a seasoned athletic trainer and physician thought it was ACL, but I called it bucket handle tear.
Nice.
So, sometimes it's just...
You just never know.
Yeah.
Yeah. My favorite, the x-ray vision, that one's always good. But I go a step further for my ligament people, and I say, I don't have MRI eyes.
Oh, that's a good one.
Yeah. Yeah, I like that one.
I feel like MRI is colloquial enough that people still kind of know what that is. I feel like x-ray is more...
Everyone wants an MRI. That's what gets me. Anytime you talk to an athlete, they always want the MRI.
I don't know. I feel like my athletes are confused on what an x-ray
really
does versus an MRI.
Yeah, every time someone comes in and is like, do you think I need an MRI? No.
They probably heard that from their parents.
No, you'll be all right.
Okay, so keeping on the topic of fractures.
Okay.
We have, this one's from Gabe R. He said, I had an opposing JV football athlete that was rolled up and presenting with severe knee pain. He reported a loud pop.
Oof.
His description screamed ligamentous rupture. I started my physical exam and his pain increased significantly. He described the pain being proximal to the actual joint line.
Interesting.
He rolled his pants a little more and his VMO was oddly rigid and spasmed.
Oh.
He was in way too much pain to move, which was a red flag for me. So I called EMS onto the field to transport. In my head, I'm like, no way is this a femur fracture. But it just seemed off, and I went with my gut, which is a moral, I feel like it's kind of like a theme along a lot of our stories. It's just like, I didn't know exactly what was happening, but I kind of had the, it didn't feel right.
Yeah.
This was before we had a vacuum splint at our school, and EMS didn't have splints, so we immobilized him with a spine board using rolled towels to better stabilize the leg. I mean, that's what they teach you in first aid.
Yeah.
All those towels. And the blankets.
Yep.
Those thick wool blankets. We found out the next day it was confirmed a distal femur fracture. I'm guessing condylar. He underwent open reduction internal fixation the same night. The next day, our AD agreed to purchase vacuum splints.
Good call. I like that.
I told him, I was like, sometimes you just have to be the person.
Yeah.
That has the unfortunate circumstance that makes a change.
Unfortunately. And you know what is the bummer? It takes stuff like that sometimes for you to get that equipment.
Yeah, really. Want to go into our next one?
All right, let's do it. Are we going ligaments now?
We are, and this one
Right ahead. I'm ready.
This one is actually sent in by Lorena, one of my best friends, and she sent us a voice memo.
So this is a great story because it's a unique injury to the knee, which I love the knee, but it's also a valuable learning experience for the student I had at the time and for myself. So I was working at a college and I was in the AT clinic, which was downstairs in a building semi-adjacent to our field. And our men's lacrosse team, club sport, was practicing on the field. Well, I was covering women's basketball, but I was also a first responder for our club sport that night. So in hindsight, I saw an athlete run down the stairs and I had noticed at some point that my student had left, but it didn't really register that the two were connected. A good 5, maybe more minutes passed. And another athlete runs down the stairs and says, "I think your student needs some help." And I was like, oh man, he did not. So of course I ran straight to the field, which I got pretty winded running upstairs. And then of course, every injury always happens on the opposite side of the field. So I was running, I saw the athlete down by the lacrosse goal and my student was just kneeling next to him, really looking like he had no idea what to do, which kind of made sense to me. And the athlete was in obvious pain. When asked the teammates, they said that their teammate had run behind the goal and he had just sort of tripped over the goal. I asked the student what he had done. He said, "I tried to extend or bend the knee, but he was really unable to, secondary to this athlete being in so much pain." So upon primary inspection, I realized that I had a pretty clear view of the tibial plateau. Then I started to palpate the patella and the joint line and inferior to the kneecap and realized that there was really no patellar tendon. The kneecap was displaced a little bit superiorly, and then the athlete had said he had heard a pop. Well, realizing that I probably needed to put him in a splint or a brace of some kind, I asked a student to grab it from the AT clinic that was actually at field level. Well, that's when I realized that in my rush to come out of the athletic training room, I had forgot my keys all the way downstairs. So naturally, I sent a student all the way downstairs to go get the splint bag. So while waiting for the splint bag, this kid's skin signs weren't looking so good. He was nauseous, said he was kind of cold. It was kind of a cold night, but he was like super sweaty, but he wasn't looking so good. So here I was having to treat him for shock. Probably it's been like 10, 15 minutes after he got injured. So I'm elevating his legs the best that I can while still stabilizing, keeping him warm. Ended up sending the kid to the emergency room due to his pain and not having some great skin signs and shock signs. He ended up seeing the team ortho the next day and then had an MRI, which revealed that he also had an ACL tear on top of the patellar tendon rupture. So he had to go through 2 major surgeries, the patellar tendon rupture and then an ACL tear. So lesson learned, always grab your keys before leaving your athletic training room, and students should never respond without telling their preceptor.
No, students should not respond.
No. That's so unfortunate to have the patellar tendon rupture and a torn ACL.
Dude, I wonder, I need to ask Lorena, I wonder if, did they use the patellar tendon for the ACL repair?
I feel like probably not. Because you need 2 bony ends to fix it into the joint where the ACL would be. It sounds like it tore through the soft tissue, not with the bone.
Oh, ruptured patellar tendon, not avulsion fracture.
Yeah, so I think that patella tendon's gone.
Oh yeah, man,
that sucks. So hamstring graft.
Well, that's a lot of force from the quad then.
Yeah.
To rupture the patellar tendon and tear the ACL, like shift that tibia forward.
Yeah, and also too to think about how, like, if his foot got stuck in the net, which way were they turning, kind of thing. Like that could also play a role, I guess. That's pretty unlucky. That's pretty unlucky. I mean, I guess. Yeah, I guess you can do both surgeries, right? Like, I feel like that's a lot, right? I don't know. Like, do you do it all in one, or do you have to do 2 surgeries?
I'm not a surgeon. I don't know.
That's a good question, too. See, this is why they get paid the big bucks.
Yeah, but I'm also thinking, like, why would they leave the patellar tendon I guess you could leave the ACL and go back in, but, like, why would you leave the patellar tendon?
Yeah.
I feel like you'd do that first.
Yeah, I think that was probably first. For sure. For sure that was probably first.
Yeah.
Because, I mean, you theoretically can live without an ACL.
See, we just got so many patella stories.
I know, that
I
was
feel like it's
interesting.
all the patella. This one's not a patella. This one's about a tibia.
Okay.
So this is from Marissa S, and she is our Precision AT partner.
Yes.
She is awesome. She helps with all of our CUs, and she also submits some great stories.
Yes.
So, you want to read this one?
Yes, absolutely. So Mara says, I saw a tibial dislocation and a terrible college rugby injury. Well, of course, rugby. That's right there. It tells you. The tibia was pushed back, and his patella was sitting like 2 inches in front of his tibia. Ooh, interesting. All skin was attached, but I could see the underside of the patella.
Isn't that like...
Whoa. Dude, that's brutal.
Yeah.
I called 911 and wouldn't let him look at it, and had to keep all other teammates away because their reactions wouldn't be good. Oh, no, not at all. When the EMT arrived, his reaction was worse than anyone's. The kid looked and then started to go into shock. I was doing per diem, and it all happened so fast that, aside from the coach, I didn't have a good follow-up. Coach said he had emergency surgery, and I'm assuming there were multiple tears to all kinds of things, but never got the official diagnosis. And sums it up with this comment perfectly. Rugby. ... Yep. That's pretty bad when the EMS crew is the one that let him into shock.
We had that. I've had that before.
That's brutal.
I've had EMS people who have been, like, yelling at people to calm down. It's like, oh, okay.
Well, yeah, the first thing you think of when I need to calm down is getting yelled at.
Yeah.
Oh, okay. I'll calm down now.
Thank you, actually. That really helped me. This isn't the only story that we don't have good follow-up on, which is just a bummer because...
Yeah.
I feel like with per diem, that's pretty common.
Yeah, that's how it goes.
Which is unfortunate. Unless you're, like, with a team. Like,
Yeah.
The only reason I got follow-up on my football athlete who I C-spined was because I had been there every week.
Yeah.
Like, every weekend. And so I got to see, like, his recovery.
How he was doing.
Right. Could you imagine just seeing...
The underside of the patella.
Right.
That's pretty brutal.
I mean, also, like, skin is so stretchy.
Yeah. That's pretty brutal. Man. Dude, I can imagine that. See, rugby, man. I couldn't do rugby. That's a different world.
Yeah, actually, I couldn't either.
Yeah.
And
Oh, really? You work football? I mean, that's one step below.
No, it is like 5,000 steps below. Rugby is like apples and oranges.
Yeah, that's true.
No thanks. I think I'm busy enough working a football game. I think rugby is just
Oh,
like,
yeah.
nope. Also, I feel like the added bonus of, like, I don't know the rules.
Yeah.
Or,
that's
like,
true.
how it goes. And so, like...
Yeah, that's something important to consider for sure.
Right. Okay, so this next one is about an LCL.
Okay.
So Marissa S said, my cool one was with, I had a kid get his legs taken out in football. Looked like an LCL, but I knew right off the bat that it was an avulsion and not a clean tear.
Ooh.
No idea why it felt so obvious to me, but I was really proud of myself when the mom called to confirm my diagnosis.
It's one of those things that you're happy you got it right, but man, it sucks for the kid.
I know. But okay.
But that's pretty good.
This is another, like, trust your gut.
Yeah, seriously.
Also, I love that she starts the story with, my cool one
So there's been other ones that haven't been as cool as that one.
So obviously an athletic trainer
Yes,
is telling this story.
big time.
We have a couple more before we go back into our patella.
Okay.
So this next one is about a bursa.
Okay, perfect. And this one is anonymous. Had a soccer player rupture their suprapatellar bursa. Whoa. That is interesting. I've never seen that before. It was like palpating a waterbed. She got pushed and fell straight onto her knee. She kept playing the rest of the half and didn't show me until halftime. Sounds like soccer. I have had plenty do that. She said at first it just felt funny to move, but the swelling and fluid by half made it too hard to move well. So she sat the rest of the game. She had good quad function though. She'd been dealing with a quad tendon strain in that area and suspected bursitis that we'd been rehabbing. And she'd been back to normal before then. We had her see the ortho the next day and we did swelling control / rehab with her. That is so interesting. I couldn't imagine just how weird that is, probably palpating that.
Honestly, I feel like I have seen a bit of bursitis. Like I've seen a good amount of bursitis.
Yes.
Which is, I feel like,
But not the rupture.
no. I've had 2 people with trochanteric bursitis.
Ooh,
I have
interesting.
someone right now, actually.
Oh, that's unfortunate.
Yeah. One was a performing artist and one was a football player.
Nice.
Yeah.
Dude, that sucks.
I know. But I love how she says it was like palpating a waterbed.
I know.
Because it like really...
I couldn't imagine that sensation on someone's like skin. Like palpating and it feels like a waterbed.
Mm-hmm.
That's so cool.
Speaking of performing arts, we have a... this next one is about a professional performing artist.
Okay.
I don't know in what like capacity. I don't know. I'm pretty sure it's more like stunts.
Okay. Oh, got it.
Or like something along those lines. You want to read it?
Yes, this one's by Anonymous.
This one's got a lot of fancy language.
All right. A professional performing artist sustained a hyperextension injury to the left knee. MRI identified chondral lesion to the medial trochlear articular surface. Athletes started rehab and their knee kept experiencing a locking sensation over the lateral aspect of the knee. Surgery was recommended. The surgeon performed a knee arthroscopy with patellar chondroplasty, defect noted during arthroscopy, and trochlear microfracture. Athletes started post-op rehab and shortly into it began complaining of the same locking sensation at the lateral knee. That is frustrating.
Mm-hmm.
The locking was intermittent, and each time the athlete came in for rehab, the locking could not be reproduced.
Which happens all the time.
Oh, of
like
course.
They're like, oh, this is hurting me, or this is doing this, but then you can't find anything.
It's just like when you take your car to the mechanic.
Right.
Just, you heard the sound, but they can't ever reproduce it.
Right.
Subjective findings sounded like there could be a lateral meniscus tear, but MRI and surgical exploration were negative for any meniscus injury. Artists felt like self-mobilizing the fibular head would sometimes help unlock the knee. One day, the athlete experienced a locking episode while on site, and I performed a very thorough assessment. After going through all special tests, which were negative, looking closely at stability and mobility of fibular head, and unsuccessful attempts to mobilize the knee to allow it to unlock, we came across a new finding. There was a small, dime-sized, palpable, and visible cyst-like ball that appeared on the lateral aspect of the knee near the fibular head all of a sudden. That's crazy.
Isn't that weird?
That is so crazy. We videoed the cyst and sent it over to the surgeon. He had the athlete return to the office the next day, and of course, no locking, and we were unable to palpate the cyst while at the MD office.
Of course.
A post-op MRI was ordered and came back positive for a loose body in the posterolateral joint space. Athlete was booked for round 2 in the OR, and the loose body was removed. Athlete was able to rehab without any locking issues after the second surgery and has returned to full sport. That's crazy.
I don't know why seeing after the second surgery and return to full sport, that kind of gave me the chills. That doesn't
Yeah.
usually happen to me. But that, I don't know why. That was like,
That's really cool. Well, you can imagine probably how much frustration that athlete had.
oh yeah.
Like, that's terrible.
Also, I'm just like, they said they experienced a locking sensation over, in the knee before surgery, which is kind of crazy that it wasn't like found unless they weren't in like that spot.
Well, yeah, I guess because you're not really like looking for it. I guess
that's true. You're kind of in like a one.
Yeah, because you
pinhole. You're in a pinhole.
Yeah, and you have all the information going into the surgery about what you're going for. So that's where you're at. Like, obviously they look to make sure, but like, I'm sure it wasn't as noticeable, so they probably didn't see it.
Mm-hmm.
That's crazy. Oh my gosh.
When I was a student, I had a performing artist who had I thought she had a loose body in her ankle.
Okay.
And I like pretty much fought my preceptor because he didn't want to do anything about it.
Yeah.
And I like really was passionate about like, I think she needs to be seen. And she like, we did all the rehab. She wasn't getting any better. But I never knew what happened.
Yeah.
to her.
I wonder what ended up being the issue.
Yeah. I don't know. But I still bet my money that there was a loose body.
You bet your bippy.
I bet my bouillon.
Bet your bippy.
Mm-hmm.
We've had this debate before.
A meniscus. We have a meniscus story,
right,
which I thought we were gonna get more meniscus.
Yeah, I'm surprised too.
But you know what? I feel like a lot of these stories, and I was kind of laughing because, like, obviously these are the dramatic stories.
Yes.
Like, they're not. You're like, oh, I had this kid with knee pain. He came in. It was.
We don't have the IT band syndrome stories.
I can tell you an IT band syndrome story. But I mean, those are the ones that like.
Yeah.
You want to tell.
Yeah, these are the standout ones.
Right. So anyway, we have a meniscus one.
Go for it.
So Marissa S said, crazy sad story that I had was a senior who was during football came to me about his knee. I told him it was a meniscus and he'd probably need surgery with how he was presenting. He finished off the season and got surgery, had a solid recovery through the winter, and returned fully for track in the spring. He came back because his knee felt wrong, and his doctor told him he needed a revision. The poor kid had to get a cadaver cartilage put in.
Interesting.
He couldn't choose when he got the surgery, just when there was a match, and his match came the week before state for varsity track. He had qualified in 3 events, and one of them was a relay. I felt so bad for him, but he recovered well, graduated, and no more knee trouble I last heard.
Nice, that's awesome.
Which, you're right, this is totally a crazy and sad story because literally what are the chances that they find a match right when he could go compete in like this
of course
big
and what he's worked so hard for,
right? But then also, like, I've never heard of a cadaver cartilage for meniscus.
Neither have I. That's interesting. That does remind me though, I had a interesting meniscus case. I had in track, one of our hurdlers had a discoid meniscus.
Oh yeah, I remember that.
Up until that point, I never knew what that was, but it's basically just a developmental deal with how the meniscus develops and the ligaments that attach to it, and the shape of the meniscus as well. We discovered that early on in the season, so there was still season to go, and he was somewhat functional. As with most meniscus stuff, there were days that it really hurt, and then there was days he felt okay. So we were able to like rehab him, get him through the season, and then he had surgery at the end of the season. So it was nice we could get him through. And towards the end, he was actually doing pretty good. There were more good days than bad days. And to make things even better, after his surgery, what I heard from like the symptoms and stuff, I almost think he was developing a pulmonary embolism post-surgery.
Oh my goodness.
Yeah. He was okay. Like, everything checked out good, but yeah, that was very interesting.
So wait, what was the discoid meniscus? What did it do?
So essentially with like a discoid, and it's been a while since I looked at it, so the shape of it's a little bit different than a normal meniscus, and that's how it gets like the discoid name. ligaments that attach to the meniscus sometimes aren't there because there's different types of discoid meniscus. So sometimes what can happen is the discoid meniscus can shift, so it can get stuck in certain areas. Also, the makeup of the meniscus is different. The connective tissue is a lot weaker than like a non-discoid meniscus would be, so it could tear easier. So it was basically, I can't remember what type he had, but it was like one of those things. I think it tore because of just how the connective tissue is weaker.
So it was not bothersome until he tore it.
No, he had one in the other knee, which makes sense because this is a developmental thing. It's just how his genetics were.
Mm-hmm.
So once he started complaining of that same pain in this knee that he had, I was like, oh, you might have the same problem. And then, yeah, our ortho confirmed it.
Wow, that's kind of crazy.
I know, it was pretty cool.
Did you tape it?
Not for him, but...
Did you have any sort of, like, tape that kind of helped relieve anything? Or did you just kind of let him go?
Most of the time we let him go. Sometimes KT tape would help.
Oh, interesting.
He really liked the the mulligan mobilization for patella pain, or for meniscus pain.
Oh,
that one really worked, and it made sense because with being discoid, there is the chance that the whole meniscus could be shifting because of the whole ligament deal. Right. So the fact that that helped does kind of make sense.
If you guys can't tell, we're fans of Mulligan.
Big fans.
Yeah.
We are not sponsored by their courses, by the way, so this is unbiased. As with any conference you go to, we disclose no conflicts of interest.
So we have two more. These next two are about patellar dislocations.
Okay.
So we sandwiched this episode with our patellas.
Of course.
Actually, I feel like it was kind of throughout too. It was just kind of like a...
Well, you know what? It gives you more to look at for the patella than just like, is it dislocated or not? Now I have to consider a fracture right in half.
Seriously. Wait till you see that x-ray.
I'm excited for that one. I can't wait.
Okay, so this one's from Haley L. She said, I had a patellar dislocation during a drill involving step-over bags. Lateral steps, too much momentum. He didn't pick his foot up high enough. The patella continued to move laterally even though the athlete didn't.
Yep.
So, simple passive extension reduced the patella.
Nice. I heard that's a very satisfying feeling. Yep.
I've never had or seen a patellar dislocation. I've seen the aftermath of one.
I have a few kids with a history of it. It makes me a little nervous.
Do you feel like you would be comfortable putting it back?
Yep, I'm ready.
I really get on my football kids about putting their knee pads down. Well, first of all, because I hate the knee, but also because...
Well, they never like their pads. They never like their thigh pads. They never like their patella pads.
This team has a problem with their shoulder pads.
What do they like to do?
Constantly... Well, they have their name on the shoulder pad, like the actual pad.
Oh, okay.
And so they tuck their jersey in the top of the shoulder pad, so you see, because you know how that's the double that comes down? They tuck it in the top one.
Interesting.
And so I'm constantly walking. We're doing pretty well right now because they know I'm going to go get them. But I only have like one or two athletes who are constantly doing it that I've had to have a talking with that I don't want them to get AC joint sprains.
I was going to say, you're going to hurt your shoulder that way.
Yeah.
These kids.
Okay, last one, patellar dislocation.
All right, this one's by Anonymous. Scramble in front of the net. The kid was abducted and someone landed on him. Ooh. He told me his knee touched the ice and that his knee was broken.
Oh, this is hockey, by the way. I don't think I wrote that.
No, it makes sense with scramble in front of the net now. He was in full pads, so shin pads tucked into the skate and over the knee covered in a sock to the mid-thigh. Did my best to calm him down and get through the back of the shin pad to feel around. The knee itself felt fine, so we helped him off the ice and to the dressing room. Got his gear off, and it looked so off. Of course, the kid looked and was like, WTF. Tried to get him to activate his quads and extend his leg fully to see if we could get it back in. Didn't go. So we patted the area, wrapped it up, and sent him to the hospital. That was traumatizing for him because it is an aggressive reduction. X-rays showed he had a deep groove and should have been very difficult to dislocate.
Wow.
Worse was he did it again at a tryout a few weeks later and then needed MPFL surgery. So we're rehabbing again post-surgery. I was going to say, shoot, like, if he has a deep groove, it probably shouldn't have, it probably made the reduction difficult. That's probably why I didn't go back easily. And like they were saying, like, shouldn't have really dislocated.
In the first
Which means if it did, I can see why surgery was needed. I bet all that connective tissue just super stretched out, and that's brutal.
Well, I mean, someone landed on him, so it was forceful.
That's true.
I was just telling this person, like, I couldn't imagine the equipment involved.
Oh my gosh, I know.
Because I'm trying to think of, even football, the knee is pretty exposed.
Yeah.
And the leg. Like, the only thing I really have to deal with is, like, if I have a shoulder injury. But, like, I feel like shoulder injuries under pads is not that bad. Like, you can feel around still.
Yeah.
Blindly.
Oh, yeah, definitely.
But I could not imagine. Like, that's just a whole nother level of hockey. Working hockey.
Yeah, that's a beast.
They've got so much equipment.
Yeah.
So I feel like you kind of have to, like, before you blindly go start working hockey, you kind of have to, like, figure that out.
Yeah, get comfortable with equipment.
Yeah.
Nice.
I don't think I have any more knee injury stories.
I think those are all my interesting ones.
I avoid the knee.
I know you do. You do not like the knee.
One of my football coaches one time came up to me and was like, "So my knee's been hurting," and I was like, "Oh."
Oh no.
And I go and I'm like, doing my tests, and I do a Lockman, and I look at him and I was like, "Have you torn your ACL before?" And he was like, "Oh yeah. And nice. I was like, "Okay, good," because I was about to like kind of worry and have to feel like I have to tell you. And then I did the other side, and I was like, "Did you tear this one too?" He's like, "Oh yeah."
Of course.
And I was like, "Oh, okay.
Got it.
Thank you." And he's got some big knees.
Yeah.
He's a big coach. Anyway, Randy, you have anything else to add?
Nope, I think that was perfect. That's all I have.
So every other episode, if you guys are new, we do education or stories. This one was a story episode. Next week, we're going back to our education. If you guys want to see those x-rays and cool, fun injury. Oh, I think we have a picture of the the skateboarder, his knee under the pad.
Oh, nice.
Maybe I'm lying, but I feel like there was more than just x-rays.
Okay, nice.
So we'll put that in our Facebook group. Again, that's facebook.com/group/ATcornerPodcast. Free to join. Just answer the questions. You'll automatically be put into our group.
Yeah.
And then if you guys liked this episode, make sure, and we haven't asked for a while, make sure you go down, scroll down. It takes 1 second, like literally probably less than a second, to rate or review us.
Yes.
Actually, I guess reviewing actually takes a little bit longer because you got to write stuff. But
the rating.
But you can rate without reviewing. You can just tap 5 stars.
But we do love the reviews.
We do.
They are fun to read.
And it helps us be put out in the atmosphere and in the world of podcasts. So anyway, you got anything else?
Nope, that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.